Hi, we're live, and I hope everyone's doing well. This is we're on YouTube Studio, and today is the 25th of May. Tomorrow is the 26th, and Saturday is the 27th. Wow, I can add. But what I am going to say is that it's Memorial Day weekend, so I hope everyone has a great Memorial Day weekend. It's really the start of summer. It's the beginning to be the end of school for kids like my grandchildren. For people graduating college, probably they've graduated already and now they're moving on to the next great thing. So hopefully everyone's doing well and hopefully everyone will have a good time. Those of you who are working like me, I hope you have a great time as well. Those of you who are in the New York area, hopefully you enjoy your Taylor Swift concert in New Jersey on Friday, Saturday, and Sunday night, 3 nights in the Big Apple. So that should be a lot of fun. Now, I'm talking about pancreatic cystic lesions today. We've spoken before about pancreatic cystic lesions. We show a lot of cases. We write about them. They're very challenging. Remember, there's a range of pancreatic cystic lesions. We always used to think about pseudocysts. Well, we still think about pseudocysts, but they seem not to be something we think about as much as we used to. We talk more about other things. And so I'm trying to straighten myself out here. So I'm looking in the right spot. Oh, yeah, that's Sam. Um, what we're trying to do is basically analyze what cystic lesions are, figure out who needs to be operated on, who needs to be followed, and who can just simply be discharged. A lot of work is going on with many different modalities, CT, MR, liquid biopsies, you name it, trying to figure out how do we manage these patients. You know from the ACR guidelines, if you find an incidental cystic lesion, you need to follow the patient for like 9 or 10 years. That's a lot of scans, that's a lot of money, that's a lot of stress for the patient. At the end of the day, the cystic lesions we follow typically are IPMNs, and only 3%, that's three, ever become malignant. 97% are benign. A lot of patients to follow. What do we do? What's the size? When do we operate? Articles have shown that when you operate on cystic pancreatic lesions, more than 60% of cases, at a minimum, even with the best of hands, are actually non aggressive, benign lesions, which could have been left alone. So there is a challenge in all of this. And pancreatic surgery is not easy, high morbidity, high mortality, no matter in whose hands you do it. So let's talk about cystic lesions from an imaging perspective. Typical cystic lesion, 1 to 3 centimeters water density, maybe a thin septation. Communicates with the pancreatic duct. The duct may or may not be enlarged. Typically, it's not enlarged. And that's an IPMN. These lesions we follow, people do fluid sampling on them. There's lots of work being done that perhaps once you do fluid sampling, you'll be able to figure out what the lesion is in terms of being aggressive or not and stop there. If we see a dilated pancreatic duct and a side branch cystic lesion, we call that a mixed type IPMN. Remember that a dilated pancreatic duct could be a main duct IPMN, and that has a higher chance of malignancy. And a mixed type IPMN equally has a higher chance of malignancy than just a simple 3 centimeter lesion projected off a normal sized pancreatic duct. We also talk about how do we manage those patients, how often we follow them, who needs EUS. Lots of interest in that because EUS is not simple. New work being done with cyst fluid perhaps will help us. There's some work from Pittsburgh, for example, where you can predict which lesions are aggressive and need to be followed or removed, and which are benign and will not need to even be followed. So there is some hope that we can make the process a little bit simpler for our patients and a little bit less stressful and a little bit cheaper. So that's all good. Okay, then we talk about cystic lesions in young patients. Cystic lesion, solid and cystic. We talk about SPEN, solid papillary epithelial and neoplasms. Usually females, usually in their teens or early 20s. They can be small, they're typically large. They have solid components, they can calcify. They need to be resected. When they're resected, you can cure the patient. Better than 90% cure rate, they're resected and there's no recurrence. When they do recur, they recur locally, you get liver mets, but it's very rare. Most are resected, and that is the end of the story. Cystic lesions can be, as long as I mentioned malignancy, let's talk about neuroendocrine tumors. We typically say a neuroendocrine tumor is vascular, 1 to 8 centimeters, no dilated pancreatic duct typically, but very vascular. both the primary and if they metastasize, nodes or liver are going to be vascular. But neuroendocrine tumors can be cystic. They can have rim enhancement. I don't think it's essentially, you're not going to see a cystic lesion that's only a cyst with no wall thickening or wall enhancement. When you see a cystic lesion with wall thickening and enhancement, to me, it's going to be a neuroendocrine tumor, or you got to prove it's not. The amount of wall thickening, the amount of cystic component will be variable, but the enhancement around the lesion makes you consider neuroendocrine tumors. Typically, the lesions do not have a dilated pancreatic duct, so that can be helpful in helping you reach the right diagnosis. We then talk about benign lesions like serous cystadenomas. Classically easy to diagnose, 2 centimeters to maybe 12 centimeters. Looks like Swiss cheese, central coarse calcification. But they vary. You may not see the Swiss cheese as much as you would like. It's better seen venous than arterial. You can see a draping vessel, and it could simulate a neuroendocrine tumor that's cystic. It can simulate other cystic pancreatic lesions, including something I'll speak about next, MCNs, mucinous cystic neoplasms, which are typically considered premalignant, while serous cystadenomas are considered benign. Serous cystadenomas, when they get large enough, can cause symptoms, as anything can, and those are the ones that typically get resected. Serous cystadenomas classically have a central calcification, but truthfully, they may not have any calcification, or calcification can be in the periphery. So there's a range of different appearances. We then talk about mucinous cystic neoplasms, 40-ish-year-old female, body of the pancreas, no dilated duct, cystic with solid component perhaps, or septations. These lesions are considered premalignant and they're resected. Recent work suggests that under 4 centimeters with normal CA19-9, you may be able to simply follow the patients. We'll see how that works out. But typically the rule is mucinous tumors, that septations or ovarian stroma, these lesions are resected and the patients are cured. Again, sometimes it's low grade, moderate grade, or high grade dysplasia. But when you start seeing thickened septations and surely any wall nodularity, those lesions are coming out. What other cystic lesions can you see? Metastasis can be cystic sometimes, but that's pretty uncommon, but you can see that from different sarcomas. That can occur. We also can talk about lymphoepithelial cyst. That's a cystic lesion that's off the border of the pancreas. Often you can't tell if it's something exophytic, like a mesenteric cyst or a duplication cyst pushing on the pancreas, rather than a lesion coming off the pancreas, because it comes off the surface. Lymphoepithelial cysts are benign. If you can recognize them, they'll leave alone lesions. If they're biopsied or resected, patients often get terrible pancreatitis. So it's an important lesion to recognize, and it's a leave-alone lesion. No chance of malignancy. Nothing else can really happen. So that kind of is a good summary. When you think about cystic lesions, they can be these indeterminate, which we need to follow, the IPMNs. They could be the benign, the serous cystadenomas, range of appearances. They could be what's considered premalignant, mucinous cystic neoplasms. It can be metastasis from neuroendocrine tumor, or rather primary neuroendocrine tumor. It can be cystic, solid components with enhancing, or just enhancing around the rim. And then we talk about things like lymphoepithelial cysts, which are leave-alone lesions. There's a lot more about this. If you go to CTisus, we have hundreds of cases. We have hundreds of cases in the quiz. We have on the App Store different apps that look at this, and lots of cases in our teaching file. It's an important topic, becoming more important by the day. And I hope this quick run through made you think a little bit more and leads you to look at more cases and learn a little bit more. So let me see, I got a comment here. Congrats, Professor Fishman, for these really helpful lectures. Greetings from Greece. Hello, everybody in Greece. I appreciate the kind words. And for everybody, that's it. Have a great day, my friends. Be good.